Hello, this is Dr. Rutledge, and commenting on the great work that's being done by Dr. Imran Abbas and his group on the mini gastric bypass and bariatric surgery, doing a safe sleeve and his other work. And they're working now on a new project, and I thought I'd comment on it. I was invited to comment, which the invitation may be rescinded after I make my comments, but I'm going to go ahead and share the screen here, and then we'll get going. Okay. Okay, mini gastric bypass, understanding comes power and safety. That's what I titled this little talk, and I hope you'll find it interesting. So the topic we are looking at is which patients should have an MGB and who should we select for the MGB, and similar kinds of questions. And a lot of people are making some good questions and have suggested some good ideas. I'll give you a kind of a biased opinion that I can summarize at the beginning, which is everybody's a good candidate for the MGB. So you can turn off the video now if you want to. But anyways, we're going to go ahead and talk about that. So okay. Reminder, MGB is nothing. It's nothing. There's no such thing as an MGB. The MGB is just an abbreviation because when I started doing it, it was basically a laparoscopic or minimally invasive version of the old-timey Billroth 2 gastrojejunostomy with an anticolic loop and a callus gastroplasty. And it's somehow gotten confused. If people would do a Billroth 2 today, it's standard general surgery, but if they do an MGB, they can receive a lot of criticism. And so my bias is that it might be helpful to remind everyone, we're talking about doing a laparoscopic gastrojejunostomy, and that's been done for 100 years. We know about this operation, and we know in particular some special additional things about the MGB, but it's just plain old general surgery that's done routinely for most of the patients that have been brought up for discussion under the criteria for which patient might be a good candidate. But there are some subtleties to this, but this is a good base. Before you go and say anything else, just remember there's no such thing as an MGB. That was just an abbreviation for an anticolic Billroth 2 gastrojejunostomy with a callus gastroplasty done minimally invasive. So we abbreviated it MGB, but it's nothing special. It's plain old general surgery. There's a lot of confusion. So some people get confused about whether the BP limb length makes any difference in percent excess weight loss. My data and data here from 10 years out now from Dr. Kular shows more percent excess weight loss as the BP limb gets longer. It just shows that there's some major differences in this. This shows that BP limb length and the hemoglobin A1C makes a difference. And there are other confusions, and we're not going to go into all that today. But is the MGB a good, safe, and effective operation? Now the IFSO has approved it, and America, we voted for Trump, so Americans, we were proud of our country, but we make mistakes, and the ASMBS still hasn't approved the MGB, but it's kind of appearing as if sooner or later they're going to have to do it, and the world will recognize the MGB. What we would like to say, or what I'd like to bring up today, is the MGB is a good, safe operation in well-trained hands like any form of surgery. Okay, but one of the most important points about the MGB, in contrast to the Roux-en-Y, in contrast to the sleeve, in contrast to other operations that have been done for bariatric surgery, it can be tailored to meet almost all needs. And I'll say almost, but it's almost all needs, as we'll see in this discussion. It's good for the usual bariatric patient, plus or minus diabetes. It's good for the super obese. In my experience, and we'll talk about this, GERD patients recognize that the MGB is actually an excellent anti-reflux procedure, and certainly better than, for example, the sleeve. It's good for difficult patients, which we'll talk about, because it can be staged, it can be reversed. It's good for borderline patients because, again, if the patient develops a disease or matures or becomes frail, the MGB is reversible within a period of 15 to 20 minutes, in my experience. And in my experience and surgeons around the world, it's good for non-obese diabetics. And of course, these are the main criteria in the discussion tonight. There's a bunch of other criteria we'll look at, but it can be tailored to meet the needs of all kinds of patients. There's been a lot of confusion about the MGB. People keep throwing dust in the air. Remember, they said, oh, they're all going to get cancer. And now we know from thousands and thousands of MGB patients around the world that cancer seems to be a very small concern, if it's a concern at all. And in fact, the MGB does things that forces the patient to eat a healthier diet, and lifestyle are the kind of primary predictors of gastric cancer. So a lot of uninformed people fear the Billroth-2. And what I find is more educated physicians, surgeons, and patients tend to select or use the Billroth-2. Okay, now, there's really no MGB to my way of thinking. It's simply a Billroth-2. And it's better to consider the MGB as a simple general surgical procedure, such as a partial gastrectomy with a gastrojejunostomy, which might be performed for a peptic ulcer or distal gastric cancer. When it's viewed in that light, almost all patients become reasonable selection, and the exclusion criteria makes a lot more sense. So let's think of it that way as we go forward. So here are some of the selections we talked about. What about adolescents, the elderly, comorbidities, GERD, hiatal hernia, low BMI? And we'll see we've got a lot of these, and we'll address each one of these, I hope, briefly, so you can hear at least my opinion, which might not be something everyone agrees with. So first, I'd like to discuss what's called the MGB paradox. Okay, so if we look in the medical literature, what we find is surgeons around the world, like Dr. Kular and others, who've had superb results for tens of thousands of patients over a decade. Now, let me say that again. The MGB paradox is there are two classes of MGB surgeons. Surgeons who have reported superb results. My own results I reported as excellent. Kular, many of my friends and surgeons who worked with me have invited me to train with them, and we have shown that there are superb results. And of course, around the world, India, other countries, Israel, have shown that the MGB in many surgeons' hands, but not all, can have spectacular results. Okay, so let me say that one more time. There are a large number of reported results of the MGB having superb, spectacular, excellent results. For example, as I say here, Kular and others. On the other hand, there are some trials, and I'll just mention two, the Y Omega trial, which was disastrous and stopped an entire nation from doing the MGB, because they said, my goodness, look at all these patients having to have emergency reversal of the MGB within 1 year, up to 20%. And then there's a recent Australian study saying 10% revision rates for a reflux in Australian MGB cases. That is 10% having surgery for failed MGBs resulting in severe bile reflux or acid reflux. Well, what we have then is two opposite results. And my simple explanation is two things. One is the surgical technique is different between the two classes of surgeons. And secondly, that the postoperative management is different in the two classes of surgeons. And I won't go into postoperative management too much tonight, but if you're interested in that, I can go into the postoperative management, which I think is done incorrectly in many cases, and what I think is a better choice. But anyways, let's go back over this again. There are two sets of outcomes of the MGB. And how do we explain that? Well, it could be that one group or another has bad data collection, or they're actually being unfaithful in reporting their results. But I think the best is that just the operations are being done differently. And I have several presentations on that. I have slides of it. I have videos of people doing it differently and having different results. And so the Australian group and others around the world who've reported poor results, and like the Y Omega trial and others, many times I think it's explainable by having different techniques. Not to be critical, but the summary of my opinion in this is, if you have bad outcomes with MGB, don't do the MGB. Or maybe you want to get tutored by someone who has had good results. So this is my two worlds theory, and I'd like to express my apologies. You don't have to listen anymore. Is my understanding of the MGB, which is my opinion, is operating with surgeons around the world, good surgeons and bad surgeons. There are surgeons who do technique that's different, that has bad results. And so good MGBs often come from surgeons with good results. And I think it's technique and post-op management related. And so that's my simplistic understanding. And with that bias in place, now we'll go forward and we'll look at the other decisions we had to make on what the advice is for operative procedures and selecting different kinds of patients. I'm not going to talk about post-op diet and lifestyle. I think it's really important. We think it can be deadly if it's misdiagnosed, such as malnutrition, weight regain, and reflux. All of these are important in the post-operative diet and lifestyle. And if you're interested in that, I'd be happy to go into detail on that topic, particularly if you have a difficult patient. In the past year, I've talked to over 350 patients from surgeons around the world who've had complications and problems, and often have been able to manage them with some post-op diet and lifestyle suggestions. So if you have a difficult patient, you're invited to call me anytime, or the patient is willing or recommended to call me directly if they wish. Okay, so let's summarize. The MGB is first simple. It's almost trivially easy to perform. It's elegant, in my opinion, in the beauty of its power and how it works, and I'm not going to go over that. I think the data is clear. It's more effective than the sleeve by far, as effective or more effective than the Roux-en-Y. It's durable now for up to 24 years. It's extremely powerful. It can be tailored to the patient. And importantly, it's reversible and revisable for some of the patients we're going to talk about. So let me say these three things again, just three separate times. It can be tailored to the patient. It can be tailored to the patient. It can be tailored to the patient, not the sleeve and not the Roux-en-Y. It's reversible easily, not the sleeve and not the Roux-en-Y. It's reversible easily. It's revisable easily, both more powerful and less powerful, or it can be completely reversed. So all of these things are important in the discussion we're about to have here. And so let's just go through some of these just as quick examples. We've got 20 some to go through, but what about the MGB in adolescents? Well, yes, it's superb, because if it turns out to be inadequate or excessive, it can be reversed easily. If there's a point in which pregnancy becomes an issue and they want to go forward and the patient is a little on the thin side, the MGB can be reversed in 20 to 60 minutes. And so it makes it an ideal treatment for severe obesity in children, or diabetes as well, because it can be tailored to the individual patient. Its choice in the elderly, again, it's a superb choice because it can be tailored. It can be done as a mild procedure, or it can be a staged procedure. Patients with comorbidities, the same. Patients with GERD, what we find is those surgeons who trained with me, Dr. Kular is a good example, and many others, they have very low rates of GERD. And in those patients who do have GERD, in my consultation with them, we have resolved it with postoperative diet and lifestyle changes. So GERD, if it's in your series, you're having high rates of GERD, don't do the MGB. My bias is another option is you could contact me and maybe we could work together and see why you're having GERD and see if there are interventions that could decrease that problem. Hiatal hernia is not a problem. The MGB is an anti-reflux procedure if you understand it. And I won't go into that right now, but it's a very good choice. Low BMI is perfect for MGB because you can tailor it to a equivalent of a Bill Roth 2 type surgery for ulcer disease, which causes minimal weight loss, but can resolve diabetes. And around the world, although not a lot of surgeons are talking about it, many surgeons that I know are doing low BMI patients. So it's an ideal operation for that group. Patients with bad dietary habits, that's a really good choice because it enforces a healthier diet. Fatty foods and sweet foods are generally interfered with by the MGB physiology. Smokers, of course, everyone wishes smokers would quit, but again, smokers deserve to have their diabetes resolved if possible. Marginal ulcers and perforation are uncommon in series of surgeons who perform the MGB and my technique. And those patients who do have marginal ulcers, I would hypothesize that the surgeons are often seeing their own errors in management come back to them, because oftentimes the marginal ulcer, perforated ulcers and bleeding ulcers are not because of acid or bile related, they're related to surgical technique and ischemia. But smokers who are obese and diabetic deserve the best possible therapy for their underlying diseases to protect them from heart attack, stroke, and death. And I think MGB is a good choice. In those cases who develop a complication, the MGB can be withdrawn easily. Alcohol use, again, the MGB is a serious treatment to try and help alcohol abusers. Alcohol can be a problem, but it's a problem for everyone, whether or not you have a sleeve, a Roux-en-Y, or an MGB. Again, the beauty of the MGB is, God forbid the patient becomes an alcohol abuser, it can be withdrawn quickly and easily if that's necessary. For patients with irritable bowel syndrome, I imagine whoever put this in doesn't know the latest research on irritable bowel syndrome. It's related to the microbiome of the patient, and the MGB is critically important for fixing that problem. Contact me for more information. Patients with NASH or cirrhosis, the MGB is the ideal choice because it can be tailored. You can do a mild first step, and then you can add to that as the patient's NASH and cirrhotic disease of the liver improves. Contact me if you'd like more details on that. Patients with minor thalassemia, this is an excellent case. If they also have obesity and other metabolic problems, the MGB is ideal because, again, if there are problems, it can be reversed or it can be tailored. Super obese, the MGB can be tailored with a longer bypass, and it's also useful as a first stage if you want to do it in steps. Those with an insulinoma, again, are an excellent choice. Patients with anemia and vegan and vegetarian patients are good choices. Chronic renal failure, we've done patients easily with this. They work well, and again, because it can be tailored. You might wish to have a massive amount of weight loss, but again, the patient may have trouble with that, and you can either do it in stages or you can turn back if your initial operation is too much. Patient wishing to become pregnant, the MGB works well with that. It improves the quality of pregnancy. And again, it's ideal because if the MGB is too much or too little, it can be modified. Collagen vascular diseases, failed restrictive procedure. Of course, that's the hottest area of MGB around the world right now. Large hiatal hernia, the MGB reduces the hiatal hernia. You may not understand that. Feel free to call me. IBD is brought up again. Psychiatric disorders, we've had a good experience with that. There are patients who fail to be able to work with their MGB post-op, but most can. And in those patients who cannot, again, the beauty of the MGB is it's easily undone. Weight loss failure after sleeve, of course, again, perfect. And Barrett's esophagus, we've seen reversal of Barrett's esophagus in the patients selected for MGB. Patients who have blood medications, and medications is a widespread confusion, but basically medications do not have to be digested. They're just absorbed passively through the gut lining. And so the MGB doesn't interfere with medications. Type 1 diabetics around the world, a number of us have done type 1 diabetics with excellent results. And inflammatory or autoinflammatory diseases are one of the best choices for MGB. And again, in the event that there's complications, the MGB is reversible and revisable. And of course, it can be tailored to the severity and the need for the operation. So I'll go ahead and stop there. Briefly, that's an overview of my opinion, and we'll go back. And so that's a brief overview. I didn't go into more detail than that. If you want more details, please feel free to contact me. I'm happy to discuss with you individual patients pre-op or post-op. I do that a lot, and I get a lot of enjoyment out of it. And in addition, if you have a difficult patient, I'm more than happy to talk with them as well. So thanks very much. I went through that quickly. I hope it didn't take too long, and we'll see you again soon. And again, I look forward to anyone contacting me and criticizing me or saying that you appreciated this presentation.